Disease relapse remains the major cause of treatment failure in patients allografted for acute myeloid leukemia. And we know already that there's a very potent and manipulable graft-versus-leukemia effect exerted in such patients. And so as we strive to improve outcomes by reducing the risk of relapse, we have to be thoughtful about how we might utilize the graft-versus-leukemia effect more rationally and more potently. So the data that is emerging is that indeed this is going to be an important route for improving outcomes in patients transplanted for AML. Just at a simple level, there's now compelling data from a number of groups that the intensity of post-transplant immunosuppression, the amount of cyclosporin a patient sees, is a big factor determining an increased risk of relapse. So it's important when we transplant patients that we're meticulous about cyclosporin levels. It's also increasingly clear that there's a group of patients in whom it may be plausible that using maintenance therapy with drugs such as FLT3 inhibitors have the opportunity to reduce the risk of relapse. Now, whether maintenance with a FLT3 inhibitor really does improve outcome is yet to be demonstrated, and there's an ongoing USCT study 1506 that's randomizing patients to getting gilteritinib post-transplant or not. It's a really important study. It's halfway through accrual, and we hope that it's going to be completed next summer. But on the basis of retrospective data, it really does look quite promising. And the mechanisms by which a FLT3 inhibitor may reduce the risk of relapse are unclear, but they're twofold. The first is that we know that patients with FLT3 positive AML relapse really quite rapidly, plausibly before an effective graft versus tumor effect has been established. So maybe just by manipulating the kinetics of disease relapse, maybe just by buying time for the graft versus tumor effect, delivery of a targeted anti-tumor well-tolerated pharmacological agents such as gilteritinib or sorafenib may just provide space in which the graft versus tumor effect become maximized. But there's also really intriguing data that sorafenib upregulates IL-15, which drives expansion of donor T cells. So these drugs may actually themselves manipulate the graft versus tumor effect through a pharmacological action. So I think it's really a very interesting area to be considering. The other alternatives would be the use of cellular therapy to optimize GVL. We know that donor lymphocyte infusions can be active in patients with relapsed disease. But the evidence to suggest that prophylactic administration of donor lymphocyte infusion is of benefit is yet lacking. And so therefore the randomized study, PRO-DLI, that's being run through the UK Transplant Trials Impact Network, led by Victoria Potter from King's, which is close to finishing recruitment, is going to be really important in deciding whether delivering cellular therapy in the form of DLI is an important way of augmenting graft versus tumor. And then finally, just to say, we're still looking for effective salvage options in those patients who do relapse. There's good evidence that azacitidine can deliver CRs in about 20% of people, and it may do that through an immunological upregulation of tumor antigens, augmenting the graft versus tumor effect. And our group also has data that combining azacitidine with lenalidomide, presumably through immunological mechanisms of augmenting GVL, can be a very effective salvage strategy. This is really important area because once patients who've relapsed after an allograft get back into CR, they then can obviously have curative second transplant or DLI. And just breaking in the last 6 months has been the data that for FLT3 positive patients who relapse, drugs such as quizartinib can be very effective salvage. So I think it's really important that we're looking in the round at mechanisms that are going to augment a graft versus tumor effect. It's important that we understand more about the biology of what drives relapse, and putting those two pieces of information together, I hope that we're going to be able to have more effective strategies critically these have to be delivered in the setting of randomized trials.